So without further ado, we can begin.
Okay, well, I'm starting, I think. Do you want to move on to the first slide? It's an absolute pleasure to talk with Mark. Mark and I've just realised we've probably known one another for 22 years, but most of our communications are either on the phone or these days through the internet. So treatment of skin disease, 20 years. Congratulations, Mark. We could have been the whole hour just talking about Mark's.
It has been a joy working with you. And I want you to know, when we first met, we had more hair and none of it was gray.
So time moves on. Well, look, the first case I'm going to present is just to show you how quickly and badly things can go wrong. So this was a lady in her early 50s who sadly developed a breast cancer. She had a mastectomy, all went well, and then she wanted a breast reconstruction. She had this thing called a trans breast cancer reconstruction, and then she seemed to get what was interpreted as a wound infection. So the breast surgeons fiddled around for a few weeks, then the microbiologists fiddled around for a few weeks, and then eventually they called us. And of course, for us, it wasn't a difficult diagnosis because this is probably the worst case of pyoderma gangrenosum I've seen. And I think that the message of this is that it needs recognizing early, and we really need to educate some of our colleagues. I think colorectal surgeons, it's part of their repertoire, but I think breast surgeons, it's not. And obviously, microbiologists are likely to come across it because one of the commonest differential diagnoses is infection. And so this patient I saw about 15 years ago, and basically the whole of her abdomen, the whole of her left breast were pyoderma gangrenosum. Now, this is a long time ago. Next slide, please. And we actually treated her with methylprednisolone, followed by cyclosporin. Now, Mark's going to talk about pyoderma gangrenosum at length in a few seconds' time. And possibly cyclosporin these days wouldn't be... other things. But it just shows that, one, very often there's no underlying condition. Obviously, we checked to make certain this lady didn't have inflammatory bowel disease, paraproteins, blood disorders, which she didn't. So we didn't find any underlying explanation for pyoderma gangrenosum. And it was very gratifying to treat. So much so that this lady was kind of, desperate, as was her husband. And her husband actually is a master cabinet maker. And I was at a fair that was selling some of his wares, and I didn't recognize him, but I bought this beautiful light shade, and he gave me the matching one, so we had a pair in gratitude for kind of sparing this poor lady. So it can be a very gratifying condition to treat. Next slide, please. And here you can see that it's literally, this was about week 8 post-initiation of methylpred and cyclosporin. And literally she was on cyclosporin for about 5 or 6 months at decreasing doses, came off cyclosporin, and she's been clear ever since. Next slide, please. And, breasts are not an uncommon site for pyoderma gangrenosum. This was an interesting lady who got herpes zoster. She got shingles. And it just didn't heal over the course of several months. And of course, the reason that she got shingles was that she got an underlying paraprotein. And if you get pyoderma gangrenosum with an underlying paraprotein, it's often an IgA paraprotein. So that was the reason why this lady developed and had persisting pyoderma gangrenosa, PG having carbonized or become pathogic within the zoster lesions. So it wasn't persisting infection, it was pyoderma that pathologized into the lesions of zoster. Next slide, please. Here's another neutrophilic dermatosis, a little bit of a quiz for this one. I'd be surprised if anybody has seen this before. So this is a lady who'd got presented with post-renal failure because she'd got a carcinoma of the cervix, which was nipping off her ureters. She'd got swollen legs as a consequence of essentially malignant lymphedema. But she had a lymphangiogram, and 24 hours later, she developed this florid eruption over her face. So, can anybody fit this together? I'll give you 2 seconds to give that some thought. Florid eruption after a lymphangiogram. Next slide, please. So here's the answer. This is an iododerma, one of the halagenodermas. And iododerma tends to be a fairly acute neutrophilic reaction to iodide. So you get these florid nodules, ulcers, rather sweet-like lesions, particularly on the face. And it's particularly common in people who've got renal failure. The reason for that being that halogens are excreted renally. So she had a big bolus dose of iodide in a radio contrast medium, and that's what's produced this. So it's just one thing to be aware of. Once you've seen these pictures, if you ever see it again, the penny will drop and you know exactly what it is. So bromine and bromides can produce a similar problem, but they tend to be more chronic, rather florid acneiform eruption because you're not getting such a big dose. Bromides are still used in cough medicines and lozenges and things like that. So they're still there to kind of catch us out. But this is a very florid, acute presentation of an iododerma. And sadly, she died because of essentially she presented with pretty advanced carcinoma of the cervix. So next slide, please. I think these are now onto Mark's cases. Yes.
Right.
So Mark, over to you.
I'm going to talk about the diagnosis, but also the treatment. And, you know, you said correctly that cyclosporin was one of our, it's to this day, one of my early treatments that I use. In our book, for many years, and it may still be, the first line therapy may be systemic steroids. And the reason is that's widely available, cheap, but it comes with a lot of baggage and a lot of side effects. And these patients are not on steroids for 1 or 2 or 3 weeks. They're on for many months. So I actually don't use systemic steroids as first-line therapy, have not in years, although when you get in trouble with the other treatments, we add it in. So first-line therapy would either be cyclosporin for a very bad flaring case, and very quickly a TNF blocker, which we reported years ago as being a very effective treatment for pyoderma gangrenosum. Let me start by talking about the diagnosis, which is not easy. I happened to be at Mount Sinai where Dr. Crohn was, and we have a huge Crohn's disease population. And so we see a new case of pyoderma gangrenosum about once a month. And in the Crohn's patients, it's very easy to make that diagnosis. In patients who don't have clear underlying diseases, it is much harder. And I'm going to show you some diagnostic papers that came out in the last couple of weeks. Well, one of them, this was primarily American, although I know Dr. Powell is from Ireland, but this was, I would call it the Delphi criteria because they did a Delphi process. Now, I was not involved in it. Next slide. I think that some of the authors on there are among the best dermatologists in the world, and very well known and published for pyoderma gangrenosum. But I would say that this one major criterion is a major flaw of those diagnostic criteria. And I'll show you why in a few minutes. You have to biopsy to make the diagnosis, and that's their only major criterion. And then you require, in addition, 4 of 8 minor criteria, next slide, which are, I think, more realistic diagnoses. Next slide. You can scroll through all of them. So you want to exclude underlying conditions like infection. Pathergy is a very specific finding. If you have a small surgery and get a large ulcer, or even just a needle and get a large ulcer, that's pathergy. That indicates pyoderma gangrenosum. If you have a history of an underlying inflammatory bowel disease or inflammatory arthritis, and you mentioned, and I agree, paraproteinemia, those are common underlying causes. If you have particularly a pustule, but a papulopustular vesicle ulcerating within 4 days rather, was there a minor criterion. The border, I think, is a very important criterion, and characteristically an undermined border that often is described, here it's described as erythematous. The real classic ones are violaceous. They, in fact, metal gun gray. I never knew what that looked like till I saw pyoderma gangrenosum, and it really is that color. They also require multiple ulcerations, at least one on the anterior lower leg. And cribiform, again, to me, cribiform scarring is very specific. I'll show you pictures of that. And then another important criterion is reduction of the ulcer within 1 month of starting immunosuppressive therapy. Now go to the next slide. These are the Paracelsus criteria that were published. I believe this was in the British Journal of Dermatology. I think they are better criteria. And they had 3 major criteria that occur in 98% of patients with pyoderma gangrenosum. One is a rapidly progressing disease. 2 is you have to exclude the other relevant differential diagnoses. And the 3rd is that reddish violaceous wound border. They then assigned a number of point scoring system to their additional criteria. And let me show those in the next slide. Next slide. So improvement by go back one. Improvement by immunosuppressive drugs is a very important criterion. Extreme pain is very characteristic, and I would say probably should be a major criterion. Localization of the lesion to trauma. So pathergy is not common, but when it occurs, it's very specific. And so that is an important sign. They report in 61 to 95% of patients with PG. And then 3 additional criteria, which I think they correctly report in up to 60%. And one is the histopathology, which shows pus, neutrophils, undermined wound borders, and then association with systemic disease. So let me take you to the next slide. And there was a beautiful paper published in the British Journal of, I'm sorry, let me go before I get to that paper. There is a real risk to biopsy. And I'll show that to you here. They looked at patients with pyoderma gangrenosum and looked at procedures they had, primarily skin procedures, and 5.5% of those procedures resulted in 15.1% of patients developing pyoderma gangrenosum. They compared the skin biopsy and small surgical procedure. The odds ratio of developing worsening was 8.65. With Mohs, it was 6.47. So I will say that surgical procedures certainly have a greater risk, but even a skin biopsy carries some risk. Next slide. This is pathergy, and this was a poor kid who I still remember every day we got bloods from him several times a week. He was incredibly ill. It was when I was a medical student, and it was the days before portacaths, venous access devices. And so we ended up, he had ulcers all over his arms from blood drawing. We ended up having to stick his foot to get blood. And every time we put a needle in, he got an ulcer of pyoderma gangrenosum there. Okay, next slide. So Michelle Min published this in the British Journal of Dermatology. It's already in print, in press. And she looked at the role of biopsy in diagnosing pyoderma gangrenosum. Next slide. And she had an enormous number of patients. These were at Harvard and at Mount Sinai. Next slide. 127 cases proved to have PG. 30 additional cases were misdiagnoses. And she looked at the Delphi and Paracelsus criteria and found that the histopathology among those 2 groups was undiscriminating, not helpful at all. Same with the Paracelsus criteria. When you applied the 2 criteria, they did not help them make the diagnosis. And in fact, disease exacerbation after biopsy, 22% developed, of the group with PG developed exacerbation. 18% of the patients with the wrong diagnosis had exacerbation after biopsy. Next slide. The point is that there were 3 discriminating features. Response to immunosuppressants separated PG from the misdiagnoses, which often, of course, are infectious. Erythematous and violaceous borders associated with systemic disease and association with systemic diseases were the 3 criteria that helped. Biopsy did not help at all. Now, I'll give one caveat there, which in my long career, I have seen one patient with lymphoma that was misdiagnosed as pyoderma gangrenosum, where the biopsy did help. But in that one patient, when I saw the patient, the lymphoma was exophytic. It was not a flat lesion or granulation tissue. It was literally tumors emerging from the skin, and it didn't look to me like pyoderma gangrenosum, but someone else had diagnosed it that way. So that's the only time where a biopsy has helped in my career of seeing hundreds of patients with pyoderma gangrenosum. And I think that Michelle Min's paper is right on. Biopsy is usually not helpful. Next slide. Now, this came from the original paper by Brunstig and Perry, in which they describe small fistula tracts from which pus can be obtained on pressure. And I actually personally find this a very valuable tool in identifying what is PG and what's not. It's not always there, but early in the course of the disease, next slide, here's what you'll see. I am squeezing on a plaque of pyoderma gangrenosum, and you see that pus is coming out of those openings to the fistulous tract. You can appreciate those tracts by the openings there. Next slide. And again here, this is actually on the vulva of a patient. I'm squeezing and you see the pus coming out of the openings of the fistulous tracts. Next slide. And here I'm injecting it and move it forward. And you see that triamcinolone acetonide is coming out of the site of the injection. Next slide. But you see that the triamcinolone acetonide is actually going through a fistulous tract and coming out about 3 or 4 centimeters below because it's connected by that fistulous tract, which is well demonstrated here. Next slide. Yep, so next slide. Now, when these heal, the openings to the fistulous tracts epithelialize, and that's why you get cribiform scarring. And when you see that, you know it was pyoderma gangrenosum. Next slide. So here is a peristomal ulcer. And the question is this an ulcer or is it peristomal pyoderma gangrenosum? And this is an ulcer. And go to the next slide. And it's caused by a poorly fitting device, which is causing the ulcer. This is peristomal PG. And you see the openings to those fistulous tracts there. Next slide. Peristomal ulcer. Next slide. Peristomal PG. You see the holes, the openings to those tracts. Next slide. Peristomal ulcer. Next slide. Peristomal PG. Next slide. Again, peristomal PG. You see those holes. Next slide. This is actually the leg of a patient where you see those, the opening, the crust over the openings to those fistulous tracts. So this is peristomal PG. Next slide. I'm going to show you just a recent breakthrough, and I will tell you, my fellow who deserves all the credit for this, his name is Sophie Gannon. This is a patient who came to me. He had 4 Mohs surgeries, and each one of them ended up developing huge ulcers. And the Mohs surgeon called me up frantic saying, I don't know what's going on. What is this? And of course, it's pathergy to the basal cell removals causing these huge ulcers. There's no basal cell left here. It's just an ulcer. And the poor guy's lost half his face. I'll show you the other side of his face in a minute. He failed high dose, first of all, TNF blockers, which we started him on, combined with cyclosporin, which didn't work, combined with prednisone, high dose. And in this photo, he's on 60 milligrams a day of prednisone and 5 milligrams per kilogram of cyclosporin, 300 milligrams. He came in and asked for physician-assisted suicide, and it really actually got to me. We had done the work on spesolimab for generalized pustular psoriasis. It was not yet available in the US. I called the company, told them, listen, I really want to try it. I think it's going to help this patient. My fellow got our IRB sending these photos to approve it in a day. And the FDA, which told us it would take 30 days, called me after 2 days and said, it's approved. The letter's in the mail. We got the drug from the company. Very grateful to them. Next slide. Here he is 5 weeks later. And he is on now 3 milligrams of prednisone and 50 milligrams of cyclosporin in this photo. Next slide. Here's the other side of his face before. Next slide. 5 weeks later. Next slide. Again before, and 5 weeks later. So he certainly had a dramatic response. He's still getting the drug. We're still following him. This is fairly recent. She's actually over in our infusion unit right now because a patient today came in with a gun to his head, saying he's going to kill himself because of facial pyoderma gangrenosum. I haven't met the patient, but we're going to try to get it for him as well. So fairly awful condition, but we do have good treatments. Next slide. It's all yours, Ian.
Right, remarkable. So perhaps on with something slightly more mundane. So I was called about this guy after I'd been in my consultant job for about 2 years. So it was quite a long time ago. His general practitioner was in a bit of a flap, thinking, well, he's got these unusual lesions on his chest and some of them are blistering. And he was thinking, well, is this chicken pox? But the patient said, well, I've had chicken pox before. So, well, yeah, go up to hospital, see if they can sort out what it is. So it was pretty evident to me when I saw him what the problem was. You can see these rather linear lesions, some of which have got little blisters towards the end, and they're all linear and orientated in the same direction. So I said, well, what is your job? And he said, well, I'm on the dole, which, if you don't understand, it means he's registered sick and unable to work, and the government therefore gives him a degree of money. So I said, well, do you do any other work? And he promptly got out of his pocket a little business card indicating he did freelance gardening. And I said, so, and this was the summertime. So I said, well, what have you been doing? And he said, well, I've been doing a bit of strimming. And if you don't know what a strimmer is, it's like it's a motorized tool which has on the end of the tool a very rapidly spinning plastic wire which cuts through vegetation. So what this guy had been doing rather stupidly in the summertime, he'd been strimming with his top off. And what happens is if he strims through plants that have photosensitizing sap, bits of that sap get onto his skin. He then is exposed to sunshine and will get phototoxic lesions and blisters. So the lesions are usually linear, and if they're bad enough or it has enough sunshine, they will blister. Next slide, please. So I should say that I said, okay, well, what you must do is these will settle down quite quickly. You'll get areas of post-inflammatory hyperpigmentation. This is something that's called strimmerdermatitis. But he's done my gardening now for the last 20 years, cash in hand, no tax. Let's just keep that to ourselves. So I was lying in bed one night, actually editing treatment of skin disease, and my phone went ping. And actually, the theme here is that of flagellate eruptions. And a mate of mine who I was at medical school with, who's a neurosurgeon, said, could you have a look at these pictures, Ian? What do you think it is? So looking at those, they'd come up very acutely, hadn't been strimming. Any thoughts for a diagnosis? Again, he's got these interesting linear lesions on his back. Now, I'd never seen this before. I'd read about it, seen photos. So I said to my mate, ask your son, has he eaten any shiitake mushrooms? So I heard him shout up to Ben, his son, Ben, have you been eating any shitty mushrooms? And I had to stop him and say, no, not shitty, Jim, shiitake mushrooms. So he shouted down and said, oh yeah, I went to Wagamama's and I had some shiitake mushrooms. So this is one of the flagellate eruptions, and one of the perhaps better known causes, but I must say I had not seen before, are eating raw, particularly raw shiitake mushrooms. Next slide, please. So it's really important to look after your colleague's son. You never know when you might need his help. So here's a list of the flagellate eruption shiitake mushrooms. Certainly it occurs with bleomycin. Phytophotodermatoses we've seen, strimmer rash being a particular example of phytophotodermatitis, jellyfish stings, but there's also one other cause. Let's have a look at the next slide. So here's a flagellate erythema, and this is an occasional manifestation of what condition? I'll give you the answer in a second. So it's dermatomyositis. So occasionally in dermatomyositis, you get a flagellate eruption, particularly on the back, not just the usual shawl eruption, not just the usual facial rash, but this flagellate eruption. It's one of the rarer cutaneous manifestations of dermatomyositis. Next slide, please. So here's classical dermatomyositis. We'll all see these cases, perhaps 1 or 2 a year, with lid swelling, violaceous, heliotrope eruption, swelling of the cheeks, often photosensitive, obviously, particularly in older people, often associated with an underlying malignancy. Next slide, please. Of course, if you see someone with dermatomyositis, look at their hands. They have invariably got signs on their hands. Nail fold telangiectasia, streaking erythema running up the backs of the fingers, Gottron's papules. Next slide, please. Get your $1,500 dermatoscope and have a real careful look at their nail folds. Just before, this is an example of Gottron's papules on the fingers, which occasionally are bad enough to ulcerate. Next slide, please. And here's a lovely dermatoscopic image of the nail folds in dermatomyositis. And a naked eye, you can see these kind of ragged nail folds. Next slide, please. But here's a type of dermatomyositis that's dead easy to miss, because you could look at this person who's got this 3 or 4 month history of hyperkeratosis and fissuring of the fingers on the palmar aspect of the fingers. Next slide, please. And you can see it on the radial aspects of the fingers there. And for all the world, you could look at that and think, well, it looks like possibly psoriasis, hyperkeratotic eczema. But this, of course, is mechanic's hands, easily confused with psoriasis, hyperkeratotic eczema. And its importance is that it's often associated with antisynthetase disease, associated with antibodies to JO1, and they're the people who can get really progressive pulmonary disease. So always, when you're looking at somebody and you think it's a new case of hyperkeratotic hand eczema or psoriasis, obviously more mistakes are made by not looking than not knowing. Look everywhere, look at their lids. Are there subtle changes of dermatomyositis? Look at their nail folds. And, you know, think about dermatomyositis. This chap actually, interestingly, within a couple of weeks of presenting with his hand eruption, developed swollen legs and a CPK of 2,000 or 3,000. So his acute myositis developed a little bit afterwards. And mercifully, he didn't actually get much in the way of pulmonary disease. And it really didn't respond at all to immunosuppressants, which the rheumatologist put him on for his muscle disease. But his hands improved with acitretin spectacularly. So as a novel use of acitretin. Next slide, please. So Mark, over to you again.
Okay, thank you. I'll go through some JAK inhibitor items that I wanted to discuss, but I will say I love those flagellate cases. And I've seen every one that was on your differential with the exception of dermatomyositis. I've not seen it. We add to that list here, I teach my residents, if you can say the word linear vesicles, it's poison ivy. Okay. And it is so common in the US, and I think you don't have that plant in Europe.
We have other things that cause phytodermatitis, and it's well, it used to be primula, but they've now got primmin-free cultivars. So it's a bit of dermatological archaeology. Right,
right. So poison ivy, poison oak, poison sumac, very common in the US. Okay, so this, of course, is vitiligo. Next slide. You do the next 3 or 4 in succession. This is atopic dermatitis, psoriatic arthritis, and alopecia areata. And of course, we now have treatments that work well, and these are the JAKs, Janus kinase inhibitors. Next. And the elephant in the room, of course, is the warnings that they all carry about cardiovascular events, cancer, blood clots, infection, and death. They all carry boxed warnings on the package inserts in the US. So next slide. Now, this is the boxed warning for over-the-counter ibuprofen. And the same box warning is in naproxen, which is over-the-counter. And it's a warning about cardiovascular events, myocardial infarction, stroke, which can be fatal. And I'll show you a little bit of data about that. But look at the gastrointestinal events, which I won't show you the data on because that is very common with JAK inhibitors. The numbers are as high as 25% of patients get some kind of gastrointestinal event, including bleeding, which is common. Next slide. So you can really use statistics to lie. So this pointed to the risk of acute myocardial infarction with NSAIDs being with 1 to 7 days of taking an over-the-counter NSAID. 92% for celecoxib, 97% for ibuprofen, 99% for the others. Now, you know that that's not the risk, but look at the wording. The risk of it causing an increased risk was as high as close to 100%. Next slide. Now, here's the real risk, and you're looking here at the odds ratio for acute myocardial infarctions. In fact, goes up. It's about 50% for many of the NSAIDs. But what you're talking about is 50% of a very uncommon event. Next slide. Here's the risk for the JAK inhibitors, which have that same box warning. It's 1.33. It's actually lower than it is for the 1 week of over-the-counter NSAIDs. Next slide. And there was a beautiful poster at our recent meeting, Fall Clinical. And look at the MACE events. That's major adverse cardiovascular events. With 15 milligrams of upadacitinib, it was 1 per 1,000 patient years. Okay, so now that's a 50% increase. Upadacitinib 30 milligrams, there was no increase. When you go to some of the others, it goes as high as 0.6 per 100 patient years. Notice that with cyclosporin, it's 2.8. There's a real increase. So let's go to the next slide. The bottom line is that, you know, a hazard ratio for these drugs that's 1.5 on a rare event is something you're not going to see unless you're actually treating your patient for 100 years. So very uncommon. Now, the reason I emphasize this is we now have drugs that are actually very safe, and I'm using them more and more. And they are now, there are many reports of them being used for conditions which we are not good at treating. And you can be the star dermatologist by using these drugs if you can afford them, because they are very expensive. The companies, however, have been very liberal about providing them at no cost when patients are in desperate circumstances. So here you see tofacitinib for cutaneous and pulmonary sarcoid. Next. Let's go through these quickly. Granuloma annulare, next. Necrobiosis lipoidica, next. SLE, next. Sjogren's syndrome, next. Dermatomyositis, next. Scleroderma, next. Morphea, next. Large vessel vasculitis and leukocytoclastic vasculitis, next. We have other treatments for chronic spontaneous urticaria, but if those don't work, this is a good one to go to. Next, ruxolitinib. Upadacitinib for hidradenitis suppurativa. Again, we have other treatments, but if they don't work adequately, here's one to go to. Next. And this is topical JAK inhibitor for lichen planus, which is not always easy to treat. So I just point out that these are fairly benign drugs, and we have actually excellent treatments for them. Next. I should mention the on-label uses. Tofacitinib and upadacitinib are approved for psoriatic arthritis, and they result in a rapid improvement in joint pain within days. Next slide. And deucravacitinib, recently approved, has data on psoriatic arthritis which show it to be beneficial. Next. Of course, these three drugs, abrocitinib, upadacitinib, and ruxolitinib cream, are approved for atopic dermatitis. Next. Baricitinib is approved in the US for alopecia areata. Hopefully, ritlecitinib will be approved sometime in the near future. Next. already approved for vitiligo, ruxolitinib cream. There's just a publication a couple of weeks ago on oral ritlecitinib for vitiligo as well. Next slide. Okay.
Okay, so interesting times. I was interested to see the use of JAK inhibitors for dermatomyositis, because cutaneous dermatomyositis can be a real struggle. And trying to access IVIG now is very, very difficult. We have it has to go to a national kind of rationing body. So it's nice to see there's some options. So one or two interesting cases of patients I've seen recently. So this is the details of a 59-year-old woman who developed sores on the vulva, which were quite painful, relatively short history, about 4 weeks. Next slide, please. Also developed ulcers within her mouth. So she'd got vaginal and oral ulcers. Next slide, please. A rather non-specific eruption in her axillae. Next slide, please. And red eyes. So one of my colleagues wondered, well, was this the first manifestation of Behçet's disease? So next slide, please. So she brought her along to a joint clinic. And if you look on that patient's palm, there's a very subtle sign. You can see that little erythematous patch. Diagnosis. You can think about that for a few seconds. Next slide, please. Because this lady had developed syphilis. So syphilis is certainly in the UK is more common now than it was at the end of the last World War. We're getting about 6,000 cases a year, and one or two things are happening which are a bit odd. It's becoming slightly more common in women, and it's becoming slightly more common in older people. And of course, the problem is that in men who have sex with men, they tend to be younger, know what the problem is, and go to STD clinics. Whereas we're likely to see atypical disease and particularly secondary disease. This was a fascinating man I saw, must have been 1992. And he basically was in his 30s and was dementing. And he developed this eruption which was spreading over his arm, and it looked rather granulomatous. We thought, is it TB, sarcoid, other granulomatous diseases? Cut a long story short, this was co-infection of syphilis with HIV. And of course, remember that occasionally you'll have negative syphilis serology in the setting of HIV. So these kind of things are around to confuse us. Next slide, please. One of the other interesting things is that primary syphilis is presenting much more frequently with oral or lip lesions. And that's because people might have protected sex if they're having vaginal or anal intercourse, but if they're having oral sex, they probably won't. So 25% of primary syphilis lesions are now presenting orally, indurated, painless, firm ulcers on the tongue, on the lip, and just about any other bodily orifice you can think of. But lip presentations are becoming more common. Next slide, please. Syphilis in the internet age, well, it's occurring, as I said, in an older people, because so often people are not using protection, particularly with the availability of PrEP. So PrEP may reduce your chance of getting HIV, but of course it's no protection against syphilis. Of course, in the internet age, we've got dating sites, internet porn, and Viagra. So this gives me a little bit of hope of sex in our older ages. Perhaps, Mark, you feel the same. Next slide, please. But clearly we don't want to catch syphilis. So here's another interesting case. Therapy, get the diagnosis right first. I was doing a minor procedures list, and a chest physician knocked on the door and said, "Oh, Ian, would you see this patient? He's come up to the chest clinic." The story was he's had a low-grade fever and a cough, and then developed a rash on his chest. He had an chest X-ray because he was coughing, which showed some minor abnormalities. And of course, the way medicine works these days, the next thing is he gets a CT scan before anybody kind of takes a history and has a thorough look. So he asked me to see him. He'd got some shotty nodes in his groin and neck. Next slide, please. This was the eruption on his chest. So he'd got this kind of erythematous eruption, slightly reticulate, a slightly unusual nodule, one of which I'd biopsied. Next slide, please. But again, Don't be afraid to look at their feet, look at their palms. And now the diagnostic signs. So this is a 79-year-old chap, ostensibly happily married and heterosexual, but the typical lesions of secondary syphilis, papulosquamous eruptions, erythematous macules on the palms and soles. So see that, think secondary syphilis till proved otherwise. So it's happening even in the 79-year-olds. To cut a long story short, he was actually bisexual and traveling down to Manchester at the weekend and having sex with other men in toilets, what is colloquially known around here as cottaging. And of course, it was a rather awkward conversation that I had to have because his daughter brought him up to the examination. So it was one of those tricky situations where you got to get rid of the daughter with a good excuse and perhaps take a slightly more thorough history. But of course, no HIV, no hepatitis B, no other sexually transmitted diseases, penicillin, it still works, thank God. Next slide, please. Here's another interesting infective lesion. I was asked to present this lady who developed this rather biolaceous and slightly wrinkly eruption on the back of her hand by my boss at the time, Colin Holden. I was asked to present him as an interesting case at the Royal Society of Medicine in 1987. As well as having this eruption on the back of a hand, one hand only, she'd also got more fear, and we wondered whether it was an interesting or unusual manifestation of necrobiosis. Next slide, please. So I presented this case, and really one of the best dermatologists I've ever worked with, who sadly died prematurely in his very early 50s of SBE, Neil Smith, stood up and said, you know, I've worked in Germany, and I just wonder whether this might be an unusual condition called acrodermatitis chronica atropicans. It's one of the late cutaneous manifestations of Lyme disease, of borreliosis. Next slide, please. So we did this lady's Lyme serology, and blow me, he was absolutely right, it was positive. So here's some manifestations of Lyme disease, erythema migrans. So there you can see erythema migrans on the thigh. And there is the causative tick that's infected with Borrelia burgdorferi. In our country, it's Ixodes damani that causes it. I think in the States, it's Ixodes ricinus. But there you can see it enjoying a meal. And that reminds me, Neil, that reminds me, Mark, you've only got 15 minutes to jet off for your lunch. Next slide, please. I hope you have something more appetizing than blood. So there's a boy who's got erythema migrans on his chest, another example of erythema migrans on the thigh, the slowly spreading erythema of characteristic of Lyme disease, maybe solitary, maybe multiple. Next slide, please. But here's a few cases of acrodermatitis that I've seen over my career, and it's very common on the knees. So much so, I now call it Borrelia knees. So can you see the characteristic, slightly purple appearance, rather violaceous, but look at that wrinkling, and look at that kind of accentuation of the follicles. Get your eye on that for the knees. Next slide, please. These were all incidental findings. Whilst I'm here, doctor, will you have a look at this? There's a chap who's got acrodermatitis on his knee, on the front of his knee. There's a lady who's got it on the side of her knee. These were all incidental findings whilst you're here. And I've had 6 cases of acrodermatitis chronica atropicans. Now, I don't know whether you get it in the US. Next slide, please. But it's certainly much more common in Europe. And that's because it tends to be caused by, rather than Borrelia burgdorferi sensu stricto, it's caused by Borrelia afzelii, which is much more common in Europe as causing European Lyme disease, whereas you've got Borrelia burgdorferi sensu stricto. Do you get acrodermatitis in the US, Mark?
No, we hardly ever see it. And it is a different Ixodes species that we see, that we have here. But literally decades ago, when I read about acrodermatitis chronica atropicans, I was coming out with my Atlas of Skin Disease, Skin and Systemic Disease, and I simply could not find a case.
Oh, well, I'll donate this picture.
Well, thank you. But the bottom line is that that we don't see it clinically here.
No. Well, it is reported in Canada. I was looking it up last night. I just thought, do they get it anywhere else in Europe? And there was quite an interesting series from Canada. So you know, it may be that people are missing it because,
Yeah.
you know, I had a baptism of fire, and having missed it once in the humiliating experience of presenting at a very posh meeting in the West End of London, you know, once seen, once pointed out, never forgotten. Mark, over to you.
So having, you know, looked for it, I can tell you, you know, I'm pretty sure that I might have seen it once, and I was not positive. In any case, you know, we have only 10 minutes, so why don't we, this is LSNA for those who don't recognize it, but why don't we open to questions?
Okay.
Right. Thank you both very much. That was a fascinating tour through a number of really interesting and challenging cases. We do have some questions. So if you like, we can go through the 3 questions, and if there's time, we can continue with the cases, and if not,
Sure.
we can wrap it up. So Dr. Jean Balani has asked, in reference, Dr. Lebwohl, to your slide about the 127 cases of PG with the 30 misdiagnoses, what percentage of those patients were actually already on therapy at the time of biopsy?
You know, I don't remember, I don't know if we even reported that detail in the article. I can tell you that it's smart of you to ask, because certainly in the group at Mount Sinai, we try not to biopsy. And many of the biopsies that were done were not on my patients because they were already getting better. So I don't know the answer to your question, Gene. I'm honored that you're on this call, on this Zoom, though.
Mark, one of the misdiagnosed PGs that we had, so a lady was admitted with, she got PG on her leg. And then one of the other inpatients said, "Doctor, I think I better tell you, but I've just seen that lady. She's gone down to the shop, bought some bleach, and was pouring it down her dressings." So I think artifact, yeah, we probably weren't, we probably didn't use the criteria we should have used, but just one thing to think about. Artifact would be the great mimic. And sadly,
I had a patient who cleaned her legs with Clorox and Brillo. Brillo's steel wool.
Yes. Yeah.
Wow. Then we have a question from Anna Eversman. How do you decide which JAK inhibitor to try? Does your first choice vary based on the diagnosis?
Completely. You know, each of the JAKs really has a different cytokine profile. And that's actually why deucravacitinib did not get a boxed warning, because pretty much it blocks IL-12 and 23 like ustekinumab, which has no boxed warnings. It does also block interferons. But there have been no side effects associated with it, and it is very specific. It does not cross-react with JAK 1, 2, and 3. So it depends entirely, Anna, on the cytokine profile, on the disease that's being looked for.
Okay. Another question, sorry, back to PG, we're just jumping around a little. If you have a patient with uncontrolled PG who requires an urgent procedure, are there any options for rapid pathogen suppression that either speakers have had success with?
Yeah, I'm sure, you know, the answer will be the same from both of us. You know, if you have no choice, high-dose systemic steroids are often used. And I would say I have not been faced with that circumstance. I would probably still use a short course of high-dose systemic steroids.
I've had that problem generally in people with either seronegative polyarthropathy or rheumatoid, and they need joint replacements, and then they've got pathergic PG in their surgical scars. And I've come across that a couple of times. And again, I think I use cyclosporin, short course of cyclosporin.
Yeah, that makes sense.
Yeah. Those are our submitted questions so far. If anyone has any more, please send them through. I had a question actually, Dr. Coulson, going back to your case of the lady with iododerma.
Oh, yes.
The presentation was also quite striking in that, you know, it picked out very distinctly, you know, the eyelids, the cheeks. Is there any sort of understanding or theory as to why it picks out those certain sites?
No, I don't know. But let me just see if I can find something. Oh, I can't find it. But a patient of mine went to a car boot sale and found this book that was written in 1891. And within it is this marvelous picture of exactly what we saw with iododerma. And I didn't have time to scan it. But it's amazing, you know, the old boys knew all about it, because of course iodides were used much more frequently then. Identical picture, lids, cheeks, big, juicy, sweetoid things. It's been around for donkey's years.
Yeah.
I guess we just don't see it as much these days.
So another question in our chat from Jacob Glickman. Has your patient received any side effects from spezlimumab or spesolimumab? Which side effects should we be concerned about with the IL-36 inhibition? Thank you.
So in the clinical trials, there were a number of patients who developed infections. Of course, when you compared them to the placebo-treated group who had pustular psoriasis, you know that serious infection, you've lost the skin barrier to infection. So they actually had a comparable, maybe even higher rate of infection. But I would say I would be concerned about infections. And indeed, our patient, the reason he came back at week 5 for his next infusion rather than week 4, now, mind you, he was on a high-dose prednisone that was being tapered and high-dose cyclosporin that was being tapered. But at week 4, he developed orchitis. And presumably that was infectious and presumably, yes, related to spesolimumab or the other immunosuppression he was on.
Yeah, great. We have got Richard from Uganda. He's asking, JAK inhibitors are not available in Uganda, and the challenge is PG in diabetic patients. What would you advise in such cases?
So if you are able to get TNF blockers, and again, they're expensive and while they may not be readily available, I must say the pharmaceutical manufacturers have been very good at simply providing it for free. But TNF blockers, and particularly infliximab and adalimumab or certolizumab, are potent enough to work for pyoderma gangrenosum.
Okay. I'm just going to jump around with the question just so that this is still related to JAK inhibitors. Jacob Levitt has asked, JAK inhibitors for PG, any use?
I can't remember if there are cases of their use. It would certainly make some sense, but I'm not sure, Jacob.
Okay. And then we've got Michael Rosenbaum asking, does ACA, so I assume acrodermatitis chronica trofficans, improve with doxycycline?
Yeah, so the erythema and that violaceous colour will go away. But if you've got the atrophy or you've got fibrosis, clearly that stays. Quite a lot of people have an associated peripheral neuropathy. So as well as getting the ACA, they've often got neuroborreliosis as well. And that doesn't improve. Once it's there, it's there. So the violaceous erythema will go, the wrinkling stays.
Great. So that looks like all of our, oh, we've got one more question, apologies. So back to PG again, what is the role of dapsone for PG?
Wow.
So, sure, happy to take that. So dapsone certainly works for neutrophilic disorders and has been used widely for them. Having failed the first time I used it for PG, and also having a very high proportion of patients whom I've treated with dapsone develop side effects, and including severe hemolytic anemia, methemoglobinemia that was scary. I mean, the patient was short of breath. So having all that happen, I do still use it mostly for dermatitis herpetiformis, but I'm very wary about using it off-label for conditions like PG. And I think that, with drugs like TNF blockers, cyclosporin, you see the patients better hours after you start the drugs. And now with spesolimab, so why would I use a drug that has a lot of side effects and doesn't work that well?
Thank you. Right, I think those are all of our questions, and I'm conscious of time as well. So I just wanted to, and many people saying thank you to both our speakers, and thank you so much for giving your time and sharing your expertise, particularly enjoying the nice little pearls or nuggets of information in between cases as well. It's been really insightful, really educational. So thank you so much. And thank you to all of our participants as well, joining from around the world. I appreciate the time zones can be challenging for some people, but we've had really great participation from everyone. So thank you for sharing the questions. And just a note that our next webinar will be the 18th of December, so be sure to sign up. there's details there. Great. Well, thank you, everybody, and have a wonderful morning, afternoon, or evening, wherever you are.
Thank you. And Ian, I learned a lot. Thank you.
Yes, well, and me much more. All the best, Mark. Thanks, Sid.
Bye-bye now.
Thanks, everybody. Bye-bye.
See everyone.